Welcome to beautiful Copenhagen, Denmark's great capital city. This year, Vital Options International took on its 6th year, providing on-site coverage of this signature gathering, the essential ESMO Congress. The European Society of Medical Oncology combined the efforts of the most important European oncology professionals with the aim of improving prevention, diagnosis, treatment, and care of cancer patients. Well, the timing could not have been better. From new therapies and integrated cutting-edge technologies to the enduring role of the patient advocacy organizations, this ESMO gathering represented the finest that the oncology community has to offer.
Jennifer, if I would now have a patient in my first consultation in Luxembourg in my hospital with advanced lung cancer, I tell him, well, listen, I have bad news and good news for you. The bad news is you have advanced disease. The good news is you'll benefit from immediate palliative care. Then probably the next thing that would happen is that the complaint department would ring me and I'd have to go up to my directors because patients wouldn't understand. Actually, physicians, many other departments wouldn't either, and I think we already mentioned it. So how did you, when you enrolled patients in the study and probably also in real life, how do you communicate that? Do you mention the word palliative care? Or?
Yeah, no, that's a great question. So, as to the point before, we do call it a palliative care team. And again, from a research perspective, which is the sort of perspective that I'm most familiar with, how we've generally explained it to patients is, building on the WHO definition. And in the US, we have an organization called the Center to Advance Palliative Care out of Mount Sinai, and that's a definition that we really like. It talks about an additional layer of support for patients with serious illness. And we basically introduce it to patients, again, in the context of a study, and explain that this study is different, that other studies are focused on treatments to treat your cancer, but this is looking at how to best take care of patients and families as they navigate their diagnosis, and talk about that there's data that having palliative care involved in patients earlier can improve their outcomes. And we explain that palliative care clinicians are specially trained in symptom management and helping patients cope with their illness. And again, I think using these definitions and explaining it to patients, we haven't had a difficult time, but it does take time to explain it. You can't just sort of say, I'm going to talk to you about palliative care or talk to you about a palliative care study and walk out of the room. I think a big testament to how important communication is we just completed a study looking at early palliative care for patients undergoing bone marrow transplant. And although not everybody undergoing bone marrow transplant is cured, it is a potentially curative procedure. So this was a large study looking at palliative care in a potentially curative population, and 98% of the patients enrolled in the study agreed to participate. So again, I really think it comes down to how we communicate with patients and families, and if we take the time to explain what palliative care is, then again, as we were saying before, everybody wants it. It sounds great. With respect to whether you call it palliative or supportive care, we talked about this a little bit earlier. Patients with cancer and their families are suffering. They want whatever you can give them. If you can give them massage, if you can give them acupuncture, if you can give them palliative care or social worker, throw on whatever you have. No matter what you do, it's never going to be enough because patients and their families are suffering. So whatever you have, give it to them.
Thank you.
I'm Hannu Tavio, prostate cancer patient, and I'm representing here Europa Omo. I'm a lawyer. I would like to have a definition because I have been 18 years a patient and it cannot be cured for 10 years, so I know what is waiting for me. I have lost some near persons for cancer in a few months. And I would like to ask you, professional special, what is the line when you finish talking patient for a dying person? Because last hours, last weeks perhaps, there is no patient for family. If you speak about only this medical dying is not an adverse event for treatment. It's something deeper and wider. So I would like to hear you that can you go to the last moment, say that patient is dying, at me least, these are living persons who are passing the line. Can you tell me somebody?
A short comment, even though I apologize, but the point of the session was rather to say that to enlarge the definition about going early, since end-of-life care is something quite. I don't know, Nathan, if you want to place a comment.
I'll say two things. Firstly, when my patients are coming towards the end of life, I'll often bring them and the family together, and I say, look, there are a lot of things on the agenda here, but I'm going to make a suggestion about 4 things that I want you to try to discuss between one another. Telling each other that you love one another, explaining what you are grateful for, asking forgiveness for things that you may have done, and forgiving for things that may have been in the past. This is not original. This is derived from the work of Ira Byrok and his work, and often people will take this as an important sort of discussion. But when you ask what do I say to a patient, I will get down to the patient at eye level, and I'll say, if I think that it may be the last time I will see them, that it's been a pleasure, it's been my privilege to work with you, that you've handled the situation with grace and bravery, and that we will continue to do everything we can to make sure you're comfortable.
Yes.
And
what I meant, can you tell still he's a patient?
beg pardon?
With last moment, you see.
But the honest truth is, I don't even know for most of my patients when the last moments are going to be. They can be at 3 o'clock in the morning, or 11 o'clock in the evening. And I can't guarantee my presence, nor can my staff.
Hi, my name is Greg, and I had my mother die of pancreas cancer. And throughout our journey, we actually treated her around the world. We went from Poland. She was misdiagnosed in Poland. We went to the United States. And I was looking for any other possible help for her, alternative help. And my question is, do you call alternative health also palliative care? Because many clinicians don't like things that are evidence-based. Some like, so some can go this step further. So do we call alternative care that it's any other possible care that's out there? Because some countries, Germany is more open to that, US is less. So my question is, how should we understand it? Is it, but not every clinician, I believe not every clinician wants to recommend things that it's not evidence-based.
Yep. Nathan?
In the umbrella of the services that we provide, we are very much guided by the International Society for Integrative Oncology Integrative Oncology, who have evidence-based guidelines of what complementary therapies are of proven value and which are not. So, and essentially, the evidence is strongest for things like touch therapies, guided imagery, yoga, acupuncture. And these sort of things we've integrated as part of our program, but things that don't have an evidence base, like herbal therapies, we try to guide people in a direction towards evidence-based things. I actually use this document a lot, giving it to patients and families to read. Because in some instances, I need to protect patients, because there is a vast industry of people selling all sorts of bogus stuff which causes real financial toxicity to patients and sometimes physical harm. I once had, I won't even detail the nightmare experiences that I've had, but I think that on the positive side, yes, the evidence-based elements of integrative therapies have a place inside the tent of palliative care.
Thank you.
I just have one point addressed to Jennifer. I think I'm right in saying that your study on lung cancer did show a survival benefit of almost 3 months, something like that, was it?
Yes, that is correct.
Okay. I mean, if there was a drug in some cancers that gave a survival benefit of 3 months, we'd all be jumping up and down begging for it. Why doesn't this happen in palliative? Is it because people just don't know? Why? We want patients to come in and say, probably, at their first appointment, I would like to make sure that you give me proper palliative care throughout my journey. Just like you would ask for a blockbuster drug or some new innovative therapy.
I think we need to hold palliative and supportive care research to the same rigor that we hold research in other areas of oncology. And so I think one of the challenges is that although our study and other studies like the ENABLE study and Camilla Zimmerman's study, which was done in Canada, had exciting results for quality of life and mood and symptoms, and several of the others for survival, I think that's still only 3 randomized studies. And I think oncologists we're used to lots of data. So I think an important message for me would be that we need to keep doing research on early palliative care, that I think the early data is encouraging, but all of those studies were based in North America. And I know my colleague Jackie Yoon, who's here, is doing a study in Australia, and many of you in the room, but I think we still need to keep this research moving forward because that's what's going to change practice.